Thank you for joining me today. My name is William Reisacker, and we're going to be talking about skin testing methods. So you have already decided you're going to do allergy testing in your patients. You've decided that you're going to do it through skin testing. You've decided on the allergens that you're going to test for and you're going to potentially treat for. Now we have to consider what type of methods are there for skin testing. Well, first, why should we even be testing for allergies? Well, we want to confirm our presumptive diagnosis. We want to potentially identify the specific foods and airborne allergens. If possible, obtaining the prior records of testing is also helpful. We want to determine the level of the patient's sensitivity to know where we should start treating them. And we want to always correlate the findings with the clinical picture. That's what separates sensitization to an allergen from actually having an allergy to that allergen. It's the clinical diagnosis. And of course, you have to know what a person is sensitive to if you're considering immunotherapy. So when should we consider allergy testing? Well, you can see the list here, but I would encourage everybody to think about allergies and allergy testing at least once during their encounter with a patient, particularly when you have a patient with many of these types of complaints and symptoms, and they've been treated through many methods and have really not been satisfied with the progress that they've achieved. So what options do we have for allergy testing? Well, there are some non-specific ways of supporting your diagnosis. Just through history and physical is one way. And of course, it's very important to take that careful social history on the patient. And pharmacologic challenge. While this may not be specific for allergic disease, because a patient with a common cold may get better when you treat them with an antihistamine, it does lend some support for your presumptive diagnosis. Specific testing can be divided up into in vivo methods or in the body, such as provocation testing or skin testing, which we're going to focus on today, as well as in vitro methods, which means testing serum-specific IgE levels. Now, the history of skin testing goes back into the 1800s. Blackley was the first one to describe skin testing, and what happened is he had a scratch on his arm and then was sitting in the grass and noticed that there was a wheel and flare reaction in that area. Noon, in the early part of the 1900s, was challenging the conjunctiva with concentrations of grass pollen, which, as you can imagine, might be irritating. Lewis and Grant introduced the prick or the puncture testing in the 1920s, and this still to this day has become the workhorse for our allergy testing. French Hansel in the 1930s suggested serial testing of allergies with a 1:10 dilution, and Dr. Rinkel suggested modifying that to a 1:5 system. So what are the advantages of skin testing? Well, there still is a bit of a higher sensitivity and specificity for skin testing. However, in vitro testing with improvements in technology has quickly been catching up. Skin testing is very reproducible. It's accessible to test. The wheel and flare reactions are very easy to read. You're able to detect all 4 types of hypersensitivity, and you can also measure the early and the late phase reactions, and you can tell based on when this reaction is occurring. A patient who you skin test in the office may call you a few hours later and mention that there's some additional swelling in the area where you tested, so you could diagnose a late phase reaction. However, they may call a couple of days later and report that there's a reaction in that area, and then you can presume from that that there's perhaps a type 4 or delayed type hypersensitivity going on for that allergen. So what are our options for skin testing techniques? Well, there's epicutaneous or surface skin testing techniques, as well as intracutaneous or deeper skin testing techniques. On the surface skin testing techniques, we have patch testing, scratch testing, and prick testing, while intracutaneous testing involves intradermal using a single dilution, using dilutional testing, or blended techniques, which use a combination of epicutaneous and intracutaneous testing. Provocation testing involves provoking symptoms by placing that allergen in a part of the body where a reaction can occur. So that can include the nose, the bronchial passageways, or the conjunctiva. And this was really some of the original descriptions of allergy testing in the office setting. As you can clearly see, this can be irritating for the patient, and one of the disadvantages is that you can only test for one allergen at a time. Patch testing has been around for a long time. This involves placing the allergen against the skin under occlusion and then observing for a delayed reaction. So the reaction is checked in 24, 48, and then 72 hours later. One of the major disadvantages is that there are some non-specific responses, and this is indicated for contactants, things that contact the skin, chemicals, and also for allergens that have not yet been extracted, such as latex. Scratch testing was the original description of skin testing by Blackley, and what this involves is making a superficial cut in the skin and then placing a test antigen right onto this partially denuded epidermis. This can be fairly painful. It's also not as reproducible as some of the other methods. It also has poor sensitivity and specificity. And so this is no longer endorsed by the major allergy academies. However, many patients will generically refer to any type of skin testing as scratch testing. Prick testing really represents the workhorse for our testing, and this is routinely used throughout the world. It's very safe, reliable. It can be done in one of two ways. The concentrated antigen can be placed on the skin, and then the prick can be done through that drop, or the concentrated antigen can be loaded onto the pricking device and then placed against the skin. It's introduced about 1 millimeter into the epidermis, and a wheel is measured at 15 minutes, and it uses a fairly straightforward 1 to 4 grading system. So this is an example of a single prick device where one allergen is placed on the skin and then the prick is done through that allergen, and the reaction is read as mentioned before. Multiple prick devices are also available, and it's been suggested that multiple prick devices can be more sensitive than single prick devices. It's also been estimated that a strong positive reaction on a prick test is roughly equivalent to a number 3 or number 4 intradermal dilutional testing endpoint. Multiple prick devices are also easy to use. They're less technique dependent than the single prick devices, and it's also very useful in being able to measure multiple allergens at one time. And I find this very helpful for children where you may only get one chance at doing this prick test, and so it's good to be able to test multiple allergens in those kids. This is a multi-test 2 applicator, and the concentrated allergens are placed inside the wells, and then the multi-test 2 applicator is placed inside those wells as well. And you can see from the picture on the right that the placement cannot be reversed because there is a T on the top of the multi-test 2 applicator and a clear post at one end of the wells, so that the orientation of the device will always be consistent and known. So placing the multi-test 2 device, you want to wipe the skin with an alcohol pad, and that removes any dirt or allergens or oil. And then you want to choose a flat, hairless part of the arm or the back. It's best to stabilize the arm by placing the hand underneath the arm, and also you can provide a little counter traction to increase the tightness of the skin. That can make it easier to apply the device, particularly in a patient who has a bit looser skin. For some of the original devices, you had to rock the device back and forth and up and down to make good contact with the skin. The newer PC or pain control devices involve placing on lightly for a second and then making a firmer press for just a couple of seconds. You want to provide moderate tension. You don't want to draw any blood on this because that indicates that you're pressing down and gaining access to the dermis, where you really want this test only to introduce allergenic extract into the epidermis, 1 to 2 millimeters. Then once you've applied the device with the allergens, you'll see little drops of liquid, and through those liquid drops, you should be able to see the indentations in a circular pattern against the skin. Then you want to wait 15 minutes. If you have one device that you're applying, you don't necessarily need to label A or 1 through 8, but if you have multiple devices, it may be helpful to do some labeling of the skin so that you know what you've placed on the skin. So after 15 minutes, you can measure the response. You also want to use positive and negative controls. That's histamine for positive and 50% glycerin as your negative control. You want to measure the wheel in millimeters. If the wheel is an oval, you want to measure from the longest axis of the oval. If there is pseudopodia or false feet that are extending out, that automatically gets a grade 4. It's difficult to measure the wheel in those settings. And any reaction that matches the negative control or the 50% glycerin is by definition negative. The wheel should be at least 2 millimeters larger than the glycerin control. And low sensitivities are grade 1 and grade 2. Grade 1 is a 4 millimeter wheel. Grade 2 is a 5 or 6 millimeter wheel. And then the higher sensitivities, grade 3 is a 7 to 9 millimeter wheel. And grade 4 is 10 millimeters or greater, or pseudopodia of any size. And this is an example of putting the multi-test 2 against the back. This is sometimes useful in young children where they are less than excited about getting this type of testing, or if there's very little surface area on their arms. Now I'll talk about intradermal testing, which is another type of skin testing, which many of you, if you've placed PPD tests on your patients, this is exactly what you're doing. You're placing about 0.02 cc's of a diluted allergen or antigen injected into the dermis. You never want to inject concentrated antigen into the dermis. And that produces a 4 millimeter wheel. That generally spreads out to about 5 millimeters just by hydrostatic forces, and then you want to measure that wheel in 10 minutes. This is more technically demanding than prick testing, and it's much more difficult to perform on children. Oftentimes, we use these techniques along with prick testing in what's called blended techniques, and there are different examples of that. This is a very sensitive and a very reproducible test. So the applications of intradermal testing, when would we consider this? Well, it can be for just a primary form of skin testing, even without prick testing. It can be used as a follow-up to a negative result on prick testing if there's still a very high suspicion of that allergen, although the implication of a positive intradermal test after a negative prick test, there's been shown to be low evidence in the literature that that's of real clinical benefit to the patient. It's also useful to help guide the starting allergen dilution for immunotherapy, particularly subcutaneous immunotherapy or SCIT. And it can also be used to perform a vial safety test for subcutaneous immunotherapy. So to do the single intradermal test, you want to prep the skin at the testing site and clean the area with alcohol. And then you want to mark the skin appropriately so that you know what you're testing in what area of the skin. Then you put approximately 0.05 cc's into the syringe. Now, as I mentioned, you're only injecting 0.01 to 0.02 cc's of antigen to make that 4 millimeter wheel. But the reason to place more of the allergen into your syringe is in case any leaks out while you place it in. Maybe if you haven't placed it in enough, you'll still have more left in the syringe to place that needle a little bit deeper and to get that 4 millimeter wheel. Now, to get that 4 millimeter wheel, you want to hold that syringe like a dart. You want to point it with bevel down. The reason you want the bevel down is so that you don't squirt yourself in the eye. If the bevel is up and it's not fully under the skin, then you'll see it'll take a direct path directly to your cornea. You want to be parallel to the skin and inject enough of the diluted extract just to make a 4 millimeter wheel. And you should really be able to see a nice, tight 4 millimeter wheel. It should be fairly bright white and it should have very delineated edges. You should almost be able to identify it from the other side of the room. And if you're not sure what a 4 millimeter wheel is, you can always look at an otic speculum and you can see what a 4 millimeter wheel should be. And you'll recognize this over time and be able to measure that with your caliper eyes. So here you can see some nice 4 millimeter wheels that have nice delineated edges on the left-hand side, and you can see you can back that up with a measurement with your measuring device. And on the right side, you can see as the reactions are occurring, you can see some of them have sort of spread out already, and these may be the reactions, or it may just be that too much was injected underneath the skin. But then you're going to observe this for 10 minutes. So after 10 minutes, you're going to measure and record the wheal size for each antigen. So what are some factors that can affect the whealing response? Well, certainly the amount and the potency of the extract that you're using. Also, the degree of sensitization of the mast cells in the skin, and that can be related to your recent exposure to the allergen or to your prior use of immunotherapy. Skin testing can be less reliable in patients who have undergone a course of subcutaneous immunotherapy years in the past. Also, the area of the body tested, with the sensitivity on the upper back being higher than in the lower arm. The age of the patient can also be a factor. Testing on the skin can be a bit less reliable in the extremes of age. In the very young and the advanced age, there could be less sensitivity. And also, medications that the patients are taking can affect the whealing response. So let's talk a little bit more about the medications that can affect the whealing response. There are some medications that can actually increase the whealing response, such as beta blockers. You can see below it some of the medications that can decrease the whealing. And then on the right, the medications that really have no effect on whealing, such as the inhaled steroids, or very short-term oral steroids, or the leukotriene modifiers, which many of our allergic patients are taking. Other factors that can affect the whealing response is the local axonal reflexes, which is why it's very important when you're doing intradermal testing to separate these tests by about 2 centimeters at least. Otherwise, you have one positive reaction and it can affect the other reaction right next to it. Also, some concomitant foods can also be reacting as well if there's cross-reactivity with the foods, or foods that just increase the sensitivity of the skin. I see that often with very acidic foods, such as smoothies or orange juice or tomato-based products. That can actually increase the whealing response, and I've also seen that increase the reaction after a subcutaneous immunotherapy injection. The circadian rhythm can also be important. The most sensitivity of the skin is later on in the evening, actually. And then there's dermatopathology. In these types of patients, it would be better to consider testing through serum-specific IgE levels. Some examples of that are dermatographism and eczema. And on the next slide, we have an example of that. This is a patient with dermatographism, and clearly this would be a patient who you would want to consider doing serum-specific IgE testing. Thanks for joining me today.